Welcome to the deep dive. Today, we're diving headfirst into a topic that is absolutely essential for anyone passionate about equine health and breeding: equine endometritis. If you've been around mares, you probably know how frustrating fertility challenges can be, and, well, this condition. It's a leading cause of those headaches. So we've compiled a stack of the latest research, clinical notes, expert insights, you name it, all about diagnosis, treatment, management. Our mission, like always, is to pull out those really important nuggets for you, those aha moments, maybe some surprising facts. We want to help you understand this critical issue, from its different forms right through to the cutting edge ways vets are tackling it.
That's right. And at its core, endometritis is simply an inflammation of the mare's uterine lining, the endometrium. But, what's truly fascinating is that it's a multifactorial disease. It's not just one single thing. It can range from a very normal transient response that pretty much every mare experiences after breeding, all the way to something much more persistent, pathological, that actively stops a mare from getting pregnant or, carrying that pregnancy.
Okay, let's unpack this. Because when we talk about endometritis, it's not just one monolithic problem, is it? Sounds like there are distinct types, and figuring those out is step one.
Absolutely. Yeah, the first type we often encounter, and it can be a bit counterintuitive actually, is persistent breeding-induced endometritis. We call it PBIE. Now, after a mare is bred, natural cover or AI, doesn't matter, her uterus has this. Well, it's a perfectly normal, healthy inflammatory response. It's basically her body's way of clearing out excess sperm, seminal fluid, any bacteria that might have tagged along. Specific white blood cells, neutrophils, think of them as the body's little cleanup crew they rush in.
Yeah.
And the uterus contracts, physically pushing everything out. In a healthy, fertile mare, this whole process, this inflammation, it resolves completely. Usually within, say, 24 to 48 hours. It's actually vital.
Okay, so that part's normal. Where does it go wrong then?
Right. The problem, the pathological part of PBIE, is when this normal beneficial inflammation just keeps going. It persists beyond that 48-hour window. It's almost like the mare's own system gets, stuck in overdrive. Instead of resolving, it creates this continuously hostile environment inside the uterus.
And that's bad news for an embryo, I'm guessing.
Exactly. It's incredibly detrimental because the embryo, it doesn't actually enter the uterus until around day 5 or 6 after ovulation. So if that environment is still inflamed, hostile, it makes it incredibly difficult for that tiny embryo to survive. This often leads to early embryonic death or just outright failure to conceive.
So what causes that failure to clear things out?
The primary cause is usually impaired uterine clearance mechanisms. We're talking about things like the uterus not contracting effectively, maybe compromised lymphatic drainage, or even anatomical defects like a pendulous uterus that hangs too low, or an incompetent cervix that doesn't seal properly, or poor perineal conformation, that allows wind sucking or air gets into the vagina, or even urine pooling.
Okay.
And what's really crucial to remember about PBIE is that it's often non-infectious. It's a sterile inflammation. The mare's own healthy response is the problem, not some invading bug.
That's fascinating. So PVIE is like the mare's body struggling to finish the cleanup job properly. But, okay, what happens when actual unwelcome guests, like bacteria or fungi, decide to set up shop? That sounds like a whole different ballgame.
It definitely is.
Yeah.
Yeah, that's where we get into infectious endometritis, or IE. This type is about an active infection. We usually distinguish between acute infectious endometritis that can present with really obvious signs like purulent vaginal discharge, matted tail hairs, sometimes even systemic signs like a fever.
Okay, the more obvious kind.
Right. And then there's chronic infectious endometritis. This persists, but is often subclinical, meaning you might not see that obvious discharge. It's sneakier. Common bacterial culprits are pretty widespread. Streptococcus equisubspecies, Zooepidemicus, that's a big one. E. coli, Pseudomonas aeruginosa, Klebsiella pneumonia, Staphylococcus aureus, the usual suspects in many cases. Less commonly, we might see fungal causes, things like Candida or Aspergillus species.
Right, and you mentioned something about biofilms. That sounds tricky.
Oh, they are. What's particularly challenging with some bacteria is their ability to form biofilms. Imagine bacteria building this sort of invisible, slimy fortress right inside the uterus. That's basically what a biofilm is. It's incredibly clever from the bacteria's point of view, but for us trying to treat it, well, antibiotics usually target individual bacteria. They often just can't penetrate this protective layer. Makes treatment a real uphill battle sometimes.
Wow. So what leads to this kind of infection?
Predisposing factors can be similar to PBIE, like that poor perineal conformation. but also things like a retained placenta after foaling, a difficult birth, what we call dystocia, or even repeated reproductive procedures if they aren't done with, strict hygiene.
Makes
And
sense.
yeah, sexually transmitted endometritis is a specific form of IE where the pathogens are actually transmitted during breeding itself.
Okay, that brings us to a third type. You mentioned one that sounds particularly resistant, almost like a permanent structural issue, not just infection or cleanup problems. What's that about?
You're absolutely right. That would be chronic lymphoplasmacytic endometritis. It's often just called endometriosis. This one isn't primarily about infection, nor is it just about failing to clear fluid. It's a chronic degenerative condition. We see it very often in older mares. It tends to be age-related.
Degenerative, like scarring.
Exactly. The key characteristic is progressive paraglandular fibrosis, essentially scar tissue forming around the tiny glands in the uterine lining. You also see infiltration of immune cells, but that fibrosis, the scarring, is the critical component.
And what does that scarring do? How does it impact pregnancy?
It has a profound impact. See those glands, they're supposed to produce uterine milk. It's this vital fluid packed with nutrients, basically the embryo's first meal before it implants. When those glands are scarred, that production is severely reduced. The scarring also messes with the vascularity, the blood flow. It just makes it really difficult for the mare's uterus to properly nourish and sustain a pregnancy.
So it's the environment itself that's damaged.
Precisely. And it's often non-infectious. Unfortunately, it can be pretty unresponsive to conventional treatments because it's a structural change, irreversible scarring. We typically need an endometrial biopsy to assess it definitively.
Okay, so with these different types, PBIE, infectious, and this endometriosis, each with its own quirks, how do veterinarians actually figure out what's going on inside the mare? It sounds like it needs, well, a multi-pronged approach, like a real detective story.
It really is a detective story. And yeah, you need all your tools. We always start with a thorough clinical history and physical examination. That means digging into the mare's reproductive past, how many cycles to conceive before, any history of early pregnancy loss, retained placenta, difficult births. All that background is crucial. Then the physical exam, meticulously assessing the vulvar and perineal conformation, looking for those issues like pneumovagina, that wind sucking, or urovagina, urine pooling. A vet might calculate a Caslix index. It's a measurement helping determine if the vulvas seal properly, and also perform a vaginal and cervical inspection looking inside.
Okay, so history and a good look. What's next in the toolkit?
Next up, and really crucial, is transrectal ultrasonography. Ultrasound. It's like giving the uterus an internal view using sound waves. Lets us see fluid buildup, maybe even small cysts that could be causing trouble.
What are you looking for specifically on ultrasound?
Well, the presence of more than, say, 2 centimeters of intrauterine fluid, IUF, especially if it's seen 24 to 48 hours after breeding, that's a very strong indicator of PBIE. Highly suggestive. We also look for excessive or persistent endometrial edema, that's swelling of the uterine lining, and we can visualize endometrial cysts directly with ultrasound.
Got it. What about checking for inflammation itself?
Right. Then there's uterine cytology. This is specifically to assess the inflammatory status by looking for neutrophils, remember, those clean-up white blood cells, right there on the uterine lining. We use a special cytobrush or a guarded swab to collect cells. And when you find, under the microscope, 5 to 10 or more neutrophils per high-power field, HPF, basically a significant cluster of these inflammatory cells, that's your clear signal of active endometritis.
Yep.
And what's important is that cytology is often considered more reliable than just doing a culture for diagnosing active inflammation. Culture tells you what bugs might be there. Cytology tells you if the uterus is actually inflamed.
Ah, I see the difference. But you still do cultures.
Oh, absolutely. To complement the cytology, we often perform uterine culture and sensitivity. The goal here is twofold. Identify any pathogenic bacteria or fungi that might be present, and critically, figure out their susceptibility to specific antibiotics. Which drugs will work? We use a guarded culture swab, again, to minimize contamination from the vagina. Now, isolating certain bacteria from a mare who's having trouble conceiving, that's significant. But you have to interpret culture results carefully.
How so?
Because environmental contamination is pretty common. So clinical correlation is always key. A positive culture doesn't automatically mean that specific bug is the cause of the problem. You need the whole picture, the cytology, the ultrasound, the history.
Right, putting all the clues together.
Exactly. And for subtle cases, or maybe subclinical ones, there's a more sensitive method. Low-volume uterine lavage cytology. Instead of just a swab, we infuse a small amount of sterile saline into the uterus, gently massage it around, and then recover that fluid for analysis. This method. Well, studies show it's about twice as sensitive as just swabbing for detecting subtle inflammation. Gives us a better sample of what's really happening inside.
Okay, that sounds thorough. And then there's the biopsy you mentioned, the gold standard.
Yes, the endometrial biopsy. This is often considered the gold standard for assessing those chronic inflammatory and especially degenerative changes, particularly the paraglandular fibrosis, the scarring that defines endometriosis. It gives us a prognostic indicator using the Kenny-Doig classification system. That's essentially a grading scale for uterine health. It helps us predict the mare's chances of actually carrying a pregnancy to term based on the tissue health.
How does that work?
It involves taking a very small tissue sample from the uterine lining using special forceps and then examining it under a microscope. It tells us about the glands, the fibrosis, inflammation, gives us that grade.
Okay, so once all that detective work is done and we have a clearer picture of which type of endometritis we're dealing with, what's the game plan? How do we actually treat these mares and, give them the best shot at a healthy pregnancy?
Right, the million-dollar question. The overarching goals for treatment are always pretty similar. Eliminate any infection if it's there, resolve the inflammation, enhance the uterus's own natural clearance mechanisms, and generally just improve the uterine environment, make it a welcoming place for an embryo.
Makes sense. So let's start with PBIE, the persistent inflammation one. What's the approach there?
Okay, for persistent breeding-induced endometritis, PBIE, where it's more about fluid clearance than an active infection, the absolute key treatment is uterine lavage, flushing. This involves infusing large volumes, we're talking 1 to 3 liters, sometimes more, of warmed, sterile saline or maybe lactated Ringer solution into the uterus, and then draining it right back out.
And timing matters, you said.
Timing is critical here. It needs to be performed 4 to 12 hours post-breeding. Why? Because we need to get all those inflammatory mediators, excess sperm, debris, flushed out before the embryo arrives in the uterus, which isn't until day 5 or 6. Get the house cleaned before the guest arrives, basically.
Got it. Flushing first. What else?
We also use ecbolic agents. These are medications that stimulate the uterus to contract. Oxytocin is a common one, usually given in small, frequent doses to help expel fluid. Cloprostenol, that's a synthetic version of a hormone called PGF2, is another option. It works similarly to oxytocin, stimulating contractions, but often has a longer duration of action.
Okay, contractions to push stuff out. What about the inflammation itself?
Good point. We often use anti-inflammatory agents. Systemic NSAIDs, like flunixin meglumine, are common to help modulate that inflammatory response. Sometimes low-dose systemic corticosteroids, like dexamethasone, are considered, though their use can be a bit controversial among vets. There's a debate about balancing the anti-inflammatory benefits against potential immune suppression.
Right.
And a really critical management step, especially for those windsuckers with poor conformation, is correcting the underlying anatomical issue. Often that means a Castellix vulvoplasty, a minor surgical procedure to partially close the upper part of the vulva and prevent air and contamination getting in. Gentle exercise can also help encourage fluid drainage.
Okay, so for PBIE, it's a lot about flushing, contracting, managing inflammation, and fixing anatomy if needed. Makes sense. But what about when there is an actual infection, bacteria, or fungus causing trouble?
Right. When it's infectious endometritis, uterine lavage is still really important. It helps physically reduce the number of pathogens, wash out pus and debris. But the primary treatment then becomes antimicrobial therapy.
Antibiotics, presumably.
Yes, and we strongly prefer intrauterine antibiotics to delivering high concentrations of the medication directly to the site of infection. And it is absolutely crucial, I can't stress this enough, that the selection of the antibiotic is guided by culture and sensitivity testing. That test tells us exactly which bugs we're fighting and which drugs will actually kill them.
So no guessing games.
No guessing games. Common choices might include penicillin, gentamicin, amikacin, ceftiofur. Depends on the bug. And a little detail. Aminoglycosides like gentamicin and amikacin, they work best in a more neutral pH environment. The mare's uterus can be a bit acidic, so we often have to buffer those antibiotics, adjust their pH before we infuse them, just to make sure they're as effective as possible. Treatment usually lasts, say, 3 to 5 days, ideally during estrus when the cervix is naturally more open.
Okay, what if it's fungus?
For fungal endometritis, which is less common but can be tough, we use intrauterine and aggressive systemic antifungals. Drugs like nystatin, clotrimazole, and piperacin B. These treatments often need to be continued for prolonged periods because fungal infections can be quite stubborn to clear.
And you mentioned biofilms earlier. Any special tricks for those?
Yeah, those slimy fortresses. We have some adjunctive therapies. Things like mucolytics and acetylcysteine or NAC can help break down thick mucus or potentially disrupt that biofilm structure. And chelating agents like tricidTA can help destabilize bacterial cell walls. They're sometimes used alongside antibiotics, especially for tricky infections like Pseudomonas.
Okay, lots of tools for infections. Now, for the toughest one, that degenerative kind, endometriosis, you said there's no cure for the scarring. So is there a silver bullet, or are we really just managing expectations?
For chronic lymphoplasmacytic endometritis and endometriosis.
Yeah.
Yeah, I have to be direct. There is unfortunately no direct cure to reverse existing endometrial fibrosis. Once that scar tissue is there, it's pretty much there to stay.
So what can you do?
The focus for these mares is really on aggressively managing any concurrent inflammation or infection using the methods we just talked about, because active inflammation can certainly make the existing condition worse. However, the primary method, and often the most successful one for getting foals from mares with moderate to severe endometriosis, say Canidoid category IIB or the third, is embryo transfer, ET.
Ah, so you bypass the problem uterus altogether.
Exactly. It's a powerful technique. You breed the mare, flush the embryo out very early, around day 7 or 8, and then transfer that embryo into a healthy recipient mare with a normal uterus. This completely bypasses the diseased uterine environment of the biological dam and dramatically improves the chances of getting a successful pregnancy and a live foal.
That makes a lot of sense. Any other options for these severe cases?
Well, there's some investigational work being done. Things like deep horn insemination, trying to place sperm closer to the ovulation site, and research into stem cell therapy, exploring if we can regenerate damaged tissue, but that's still very much experimental at this stage. ET is the mainstay for severe cases right now.
Okay. So after all this effort, the diagnostics, the treatments, maybe even ET, what's the general outlook? How do these mares fare for future pregnancies? And what does a breeder need to keep in mind long term?
It really comes down to a tailored approach for future breeding, based squarely on the specific diagnosis the mare received. We focus on things like optimal timing for breeding, often trying to minimize the number of breedings per cycle to reduce uterine irritation. Consistent post-breeding management, especially for those susceptible mares, is key. Flushing, ecbolics, etc. And always strict sterile technique during any reproductive procedure. Its meticulous work requires real diligence.
And the prognosis itself, does it vary a lot?
Oh, absolutely. The prognosis really varies significantly depending on the type of endometritis. For PBIE, the outlook is generally good to excellent, especially if it's managed properly, and any underlying anatomical issues, like needing a Caslix, are corrected. Those mares can often go on to have successful breeding careers.
That's good news. What about infections?
For infectious endometritis, the prognosis is generally good to fair if you get targeted therapy based on culture and sensitivity. Knowing what you're fighting and what kills it makes a huge difference. However, the prognosis can definitely be poorer if you're dealing with, say, antibiotic-resistant organisms or if there's significant biofilm formation involved. Those cases are just tougher nuts to crack.
Right. And the endometriosis cases, the scarring.
That's where the prognosis is most guarded. For chronic lymphoplasmacytic endometriosis, if it's mild, maybe a category IA on the Canidoig scale, the prognosis can still be fair to good, provided any active inflammation is aggressively managed. But for moderate to severe cases, categories IID and 3, the prognosis for that mare carrying her own foal naturally is guarded to poor. That's due to those irreversible fibrotic changes we talked about. The uterine environment just isn't capable anymore.
So for those, ET is really the main path forward if you want a foal.
Exactly. As we mentioned, embryo transfer, ET, remains the most viable and often really the only successful option for these mares with significant endometriosis to produce offspring. So, in conclusion, successfully managing equine endometritis, it really requires a truly comprehensive understanding. You need to understand the mare's uterine physiology. You need meticulous diagnostic workup, and then a tailored, persistent approach to treatment, often combining multiple therapies. It's definitely a testament to the dedication involved in equine reproduction.
Wow, what a deep dive into equine endometritis, seriously. From understanding those, subtle differences between the types of inflammation to the really ingenious methods vets use for diagnosis and treatment, it's clear this isn't a simple issue, not a one-size-fits-all kind of problem at all.
No, it's definitely not. It truly highlights the incredible complexity of the mare's reproductive system. And it really underscores the crucial role of precise diagnosis and those carefully tailored treatment plans in tackling mare infertility. It's a field that's constantly evolving, too.
It really makes you appreciate the dedication, doesn't it? And the scientific innovation involved in equine reproduction. Just thinking about how a tiny embryo manages to survive and thrive, but only if that uterine home is absolutely perfect, and how much scientific effort and just sheer care goes into trying to ensure that it's such a delicate balance. And sometimes, like with PBIE, the biggest challenge comes from the mare's own body, just trying maybe a little too hard to do its job. Lots to think about there.